Hello, I am Professor Sims, and in this video I will discuss the integumentary system. This is the third in a series of 10 lessons held as part of my Anatomy and Physiology 1 course. If you are a student currently enrolled in this course, please consult the syllabus and course Moodle site for assignments, quizzes, due dates, and other course information. In this unit, we will learn about the integumentary system and the roles it plays in homeostasis, the layers of the skin and the function of each layer, accessory structures of the skin and the functions of each of those, several common diseases, disorders, and injuries that affect the integumentary system, and the treatments for those. Finally, we'll discuss the changes that occur in the skin during aging. The integumentary system, also known as the skin, is a complex structure with tissues collaborating to perform several vital functions. Some of these include protecting the underlying tissues and organs against impact abrasion, fluid loss, and chemical attack. We get rid of salts, water, and organic waste via the various integumentary glands. The skin helps to maintain our normal body temperature through insulation and evaporative cooling via sweating, and it's the site of vitamin D production and production of melanin and keratin. There are receptors in the skin that allow us to detect touch, pressure, pain, and temperature. Skin's the largest organ of the body. It encompasses about 16% of the body mass. Figure 5.2 shows the two main layers of the integumentary system: the epidermis, made of closely packed epithelial cells, and the dermis, made of dense, irregular connective tissue that houses blood vessels, hair follicles, sweat glands, and other structures. The third unofficial skin layer lies beneath the dermis. It's called the hypodermis. The hypodermis is composed mainly of loose connective tissue and fatty tissues, which we learned about in lesson 2. The epidermis, the outermost layer of skin, is composed of keratinized, stratified, squamous epithelium, organized into several distinct strata. The innermost layer, the stratum basale, is where cells are actively dividing. This layer contains basal cells responsible for generating keratinocytes. Above this is the stratum spinosum, where cells flatten and develop spiky projections resembling spines under the microscope. The stratum granulosum consists of flattened cells containing granules used in lipid and protein synthesis, contributing to the skin's barrier function. In regions of the body with thick skin, like the palms of the hands and soles of the feet, the stratum lucidium appears as a translucent layer, while the outermost layer, the stratum corneum, is composed of dead, flattened, and fully keratinized cells, forming a protective barrier against external elements. Figures 5.5 and 5.6 show the layers of the epidermis and the different types of cells therein. The stratum basale, the deepest layer, attaches to the dermis via collagen fibers and includes basal cells, Merkel cells, and melanocytes. Merkel cells function as receptors for touch, and melanocytes produce the pigment melanin, providing color to hair and skin. Fingerprints form where the stratum basale meets the papillae of the underlying dermal layer. The stratum spinosum is spiny in appearance due to the protruding cell processes, and it includes Langerhans cells that function as macrophages, which help protect us as part of the normal immune system functioning. The stratum granulosum has a grainy appearance, and its keratinocytes produce keratin. It is a thin layer, only 3 to 5 cells thick, in which the cells start to flatten out and the nucleus disintegrates. The stratum lucidium is the clear layer, and it's found only on the palms of the hands or soles of the feet. It's a clear band several layers thick with keratin granules adhered to collagen fibers. There are no nuclei or organelles, so it's basically a few rows of flat, dead keratinocyte cells. And finally, the most superficial layer, the stratum corneum, consists of 15 to 30 layers of cells. It's thicker in parts of the body where friction occurs. The cells flake off through wear and tear, and this functions to protect from abrasion, microbial penetration, and other chemical and physical hazards. The dermis houses blood and lymph vessels, nerves, hair follicles, and sweat glands. It is the integumentary system's core, comprising two main regions, the papillary layer and the reticular layer. The papillary layer is the uppermost portion of the dermis, located just below the epidermis. It comprises loose connective tissue containing capillaries, nerve endings, and other small structures. The primary role of the papillary layer is to provide structural support to the epidermis and facilitate nutrient exchange between the dermis and the epidermis. Dermal papillae are small finger-like projections extending from the papillary layer into the epidermis. They increase the surface area of the dermal-epidermal junction, strengthening the connection between the two layers. Dermal papillae house capillaries that contribute to the nourishment of the overlying epidermal cells and contain sensory receptors for touch. The reticular layer is the deeper and thicker portion of the dermis, situated below the papillary layer. It is composed of dense, irregular connective tissue, providing strength and elasticity to the skin. The reticular layer houses various structures, including blood vessels, sweat, sebaceous glands, hair follicles, and sensory receptors. It contributes to the overall structural integrity and flexibility of the skin. And the dermis has an extensive blood and lymph supply. Blood supplies both the dermal and epidermal layers. The lymph supply returns excess fluid to our venous blood supply to prevent tissue edema. The nerve supply to the dermis is important in both motor commands and sensory input from the receptors found in the skin, and there are many invaginations like hair, sebaceous oil glands, sweat glands, and even our nails. Cleavage lies within the dermis. Collagen and elastic fibers are arranged in parallel bundles, oriented to resist forces applied to the skin during normal movement. The resulting pattern of fiber bundles establishes the lines of cleavage, and these lines are clinically significant. A cut parallel to a cleavage line will usually remain closed and heal with little scarring, whereas a cut at a right angle to a cleavage line will be pulled open as movement occurs and results in greater scarring. The hypodermis, also known as the subcutaneous layer, is located below the dermis. It primarily consists of adipose tissue and loose connective tissue. The hypodermis serves several important functions, including insulation, energy storage, and cushioning for underlying structures. Additionally, it plays a role in regulating body temperature by insulating the body from temperature changes in the external environment. The hypodermis also contains blood vessels and nerves that supply the skin and underlying tissues. While not technically part of the skin, the hypodermis is closely associated with skin function and overall body homeostasis. Figure 5.7 shows the two main layers, the dermis, the papillary layer, and the reticular layer. Both are made of connective tissue with fibers of collagen extending from one to the other, making the border between the two somewhat indistinct. The dermal papillae extending into the epidermis belong to the papillary layer, whereas the dense collagen fiber bundles below belong to the reticular layer.
The skin is a remarkable organ, acting as the first line of defense from the elements that surround us. It keeps bacteria out and water and heat in. So let's check out the structure of skin. Our skin is made of two regions, a thin outer layer, which is the epidermis, and a thicker inner layer called the dermis. The dermis, which is a tough layer of fibrous connective tissue, is vascularized, getting its nutrients from the bloodstream. The epidermis, which is made of epithelial tissue, is avascular, so it gets nutrients by diffusion through the tissue fluid from the dermis. In addition, below the dermis is the subcutaneous layer, also called the hypodermis. This is made predominantly of adipose tissue, and it anchors the skin to other structures below. Now let's zoom in on the epidermis, the thin outer layer of the skin. This is made of keratinized stratified squamous epithelium, made of 4 different cell types in 5 layers. The deepest layer, the one attached to the dermis, is called the stratum basale, meaning basal layer. This is made of a single row of cells, most of which are called keratinocytes. These are rapidly dividing all the time, pushing new cells up into the layers above to help regenerate dead skin and producing lots of keratin as they do so. This is necessary because millions of dead keratinocytes rub off your skin every day due to friction, and even more from your hands and feet. So these constantly dividing cells in the stratum basale ensure that a new epidermis forms every few weeks so that we always have our skin intact. This layer also contains melanocytes, which produce melanin, and tactile cells, which act as the sensory receptor for touch. Above this is the stratum spinosum, meaning prickly layer. This section is several layers of cells thick and is full of cells with a web-like system of intermediate filaments attached to desmosomes. They look kind of spiky, so they are sometimes called prickly cells. cells. Here we can also find dendritic cells, which ingest foreign substances and activate the immune system, which we will talk about later. Next is the stratum granulosum, or granular layer. This is 4 to 6 cell layers thick, and in this section, keratinization begins as cells continue to move their way upwards from the basal layer. This is when the cells get far enough from the dermal capillaries below to receive sufficient nutrients, so the cells fill up with keratin as they die, and they flatten while the organelles disintegrate. This makes the cell tougher and scalier, which allows for the outer layers to better protect the body. Above this is the stratum lucidum, or the clear layer. This is 2 or 3 cell layers thick, made of dead keratinocytes that have become flat and clear. This is where they begin to aggregate into arrays called tonofilaments. And lastly, there is the stratum corneum, or horny layer. This outermost section is 20 to 30 cell layers thick, and all of these cells are anucleated, meaning the nucleus has disintegrated. So it's incredible to think that all the cells covering the outside of your body are actually dead, but they are dead in a specialized way, with thick plasma membranes surrounding lots of keratin. These dead cells protect all the living ones inside from all the outside dangers. With the epidermis covered, let's go a little deeper and talk about the dermis. This is made of strong and flexible connective tissue and is full of nerves and blood vessels. This is also where hair follicles begin. The dermis has 2 sections, the papillary layer and the reticular layer. Descending from the epidermis, we enter the papillary layer, which is very thin, made of areolar connective tissue and a loose network of collagen and elastic fibers. This leaves room for defensive cells to patrol the area for bacteria that may have made it through the skin. The word papillary refers to the projections from the surface of this layer, which are called dermal papillae, that stick out into the epidermis above. These contain lots of tactile cells, as described previously. In areas where there is lots of friction, like the hands, these papillae sit on mounds called dermal ridges, which cause ridges in the epidermis as well, which are meant to enhance the gripping ability of the fingers, and they are visible as the lines on our fingertips that make our unique fingerprints. Below this papillary layer sits the reticular layer, which is most of the dermis, and it is made of dense, fibrous connective tissue that is arranged irregularly. A network of blood vessels sits below this, just before the hypodermis. What else can we say about the skin? We mentioned that the stratum basale also contains melanocytes, which produce melanin. This is a pigment molecule, and this is one of the components of the skin that determines its color and protects the skin from ultraviolet radiation. The other pigments responsible for skin color are keratin, which is yellow-orange, and hemoglobin, which is red when oxygenated.
Pigmentation in the skin is derived from melanin, keratin, and hemoglobin. Melanin has variations in hue and intensity from reddish brown to yellow brown to brown black to black, and is responsible for darker skin colors. Skin tone is determined by the amount of melanin produced, not the number of melanocytes. Variations in gene activity will produce this variation in color. Individuals with darker skin tones naturally produce more melanin, and exposure to ultraviolet light stimulates melanin production as well, and this leads to the phenomenon of tanning. Irregular accumulation of melanocytes can result in the formation of freckles and moles on the skin. This intricate interplay of pigments and their regulation by melanocytes contributes to the diversity of skin color and patterns. Figure 5.8 illustrates how increased melanin production by melanocytes in the stratum basale makes skin appear darker. This increased melanin production provides a natural defense against the harmful effects of ultraviolet radiation, as it absorbs and disperses the UVs and prevents damage to DNA and the skin cells.
Other components of the integumentary system, which are called skin appendages. First, there is hair. Of course, most of us have lots of hair on our heads, but there is also hair all over the body, including eyelashes and nose hairs, and these all have specific protective functions. So what is a hair made of exactly? As it turns out, a hair is a flexible strand made largely of dead keratinized cells. This is hard keratin, which is a bit different from the soft keratin found in cells of the epidermis, which makes them more durable and not as flaky. Hairs are produced by hair follicles. These possess a root, which is the part deep inside the follicle where keratinization is happening, and a shaft, the part closer to the surface of the skin, and then extending outside the body where keratinization is complete. The hair itself consists of 3 layers of cells. The innermost is the medulla, containing large cells and soft keratin. Next is the cortex, which is several layers of flattened cells. And lastly, there is the cuticle, which is a single layer of overlapping cells, the most keratinized cells in the hair. As for the follicle the hair sits in, this also has some structure to it. In general, a hair follicle is a pocket that folds down from the surface of the epidermis down into the dermis, about 4 millimeters below the surface. The deep end then expands slightly to form a hair bulb. A bundle of nerve endings attach to the bulb and act as a receptor, responding to any bending of the hair and alerting the brain in case an insect is there or something of the like. A little bit of dermal tissue called a hair papilla protrudes into the bulb, which supplies signals and nutrients to the hair so it can grow. The wall of each follicle has a few layers. The outermost is the peripheral connective tissue sheath, derived from the dermis. Next is the glassy membrane, derived from the basal lamina. And then there is the innermost epithelial root sheath, derived from the epidermis. This last section has an external part and an internal part, which thins as it approaches the bulb. The cells Cells that actively divide are found in the hair matrix, which push existing cells upwards as they divide, causing the hair to grow. In addition, each follicle has an erector pili. This is a small bundle of muscle cells that can contract and pull the follicle in such a way that the surface of the skin dimples out, producing what we refer to as goosebumps when cold or afraid. Our body hair is pretty sparse, so this no longer serves much purpose, but for much furrier mammals, it is an important defense mechanism for trapping heat and intimidating enemies. Hair can either be vellus hair, which is pale and fine, or terminal hair, which is darker and more coarse, like hair of the eyebrows and scalp. The nails found on our fingers and toes are also part of the integumentary system. These are products of a modification of the epidermis. Just like with hair, in contrast to the soft keratin of the skin, nails contain hard keratin, making them great tools for scratching or picking up objects. Each nail has a free edge, which is the very tip, then a body, which is most of what we see, and then a proximal root, which is embedded in the skin. The part of the epidermis the nail sits on is called the nail bed, and the nail grows out of the nail matrix, which pushes the nail outwards across the nail bed as these cells divide. There are also skin folds overlapping the borders of the nail, which are called nail folds, sitting on the lateral and proximal borders, and the latter extends onto the nail as the eponychium. At the edge of the finger is the hyponychium, where dirt tends to collect. The last part of the integumentary system we must mention is the vast collection of glands that can be found. First up are the sweat glands, also known as sudoriferous glands. These are found almost everywhere on the surface of the skin, totaling up to around 3 million. There are two types of sweat glands. The first is called eccrine or merocrine sweat glands. Most of them are of this type, and it consists of a coiled tube. Secretion occurs in the dermis, and the resulting fluid, or sweat, travels through the tube towards a funnel-shaped opening called a pore. Sweat is 99% water, but it contains some salts and metabolic wastes, among other things. Sweat is also secreted by apocrine sweat glands, which are far fewer, found only in certain areas, and secrete fat and protein components along with the normal mixture, which is the cause of body odor. Ceruminous glands and mammary glands are also types of apocrine glands, which produce earwax and breast milk. Beyond sweat glands, there are sebaceous glands, also known as oil glands. These are branched alveolar glands that secrete sebum, which is made of oily lipids. This will soften and lubricate hair and skin, slowing water loss and killing certain bacteria.
Accessory structures of the skin, including hair, nails, sweat glands, and sebaceous glands, have an embryonic origin in the epidermidis and can extend into the dermis and hypodermis. Hair growth begins at the hair bulb with mitotically active basal cells forming the hair matrix. The hair shaft is composed of layers including the medulla, cortex, and cuticle. There are two types of hair: terminal hairs, which are large, coarse, and darkly pigmented, found in our scalp and our armpits, and vellus hairs, which are small, shorter, delicate hairs found on the general overall body surface. Hair growth occurs in the anagen, catagen, and telogen phases, with hormonal and dietary changes influencing hair loss. Hair color, like skin color, results from melanin produced by melanocytes. Aging decreases melanin production, leading to gray and white hair. Nails, forming on the nail bed at the tips of fingers and toes, consists of densely packed dead keratinocytes. The nail root, with proliferating cells from the stratum basale, enables continuous nail growth. Sweat glands developed from epidermal projections produce sweat for thermoregulation. Eccrine glands release hypotonic sweat, while apocrine glands, associated with hair follicles, produce thicker sweat with organic compounds. Sebaceous glands, found all over the body, secrete sebum to lubricate and waterproof the skin and hair. Sebum, a mixture of lipids, has antibacterial properties and prevents water loss from the skin. Sebaceous gland activity is stimulated by hormones, becoming more active during puberty. Figures 5.11 and 5.14 illustrate the accessory structures of the skin, including all of the parts of the hair and hair follicle, as well as the relative locations of the eccrine sweat glands, pores, and skin surface. The hair follicle extends from the epidermal surface into the dermis. The erector pili muscle, which is this muscle here, is a smooth muscle attached to the hair follicle, and it is what is responsible for goosebumps. The skin acts as a barrier against elements like wind, water, UV, etc. It defends against water loss through keratin and glycolipids in the stratum corneum and acts as a first-line defense against abrasive activities and microbial colonization. Sweat, produced by sweat glands, contains dermcidin, which has antibiotic properties and protects the body from pathogenic microbes. Sensory function is facilitated by the skin's ability to sense changes in the environment. The epidermis, dermis, and hypodermis contain specialized sensory nerve structures, including touch receptors like Meissner corpuscles and Vincentian corpuscles. Sensory nerves connected to hair follicles, along with pain and temperature receptors, contribute to rich innervation, enabling the perception of the environment. The integumentary system also helps with thermoregulation. Like we've mentioned, sweat glands release substances to cool the body, even during insensible perspiration. Arterioles in the dermis dilate to dissipate excess heat, and then in cold conditions, the arterioles constrict to conserve heat. Vitamin D synthesis is another key function, with the epidermis producing vitamin D when exposed to UV radiation. This synthesis, essential for calcium and phosphorus absorption and bone health, can be hindered by insufficient sun exposure, leading to conditions like rickets. In modern society, vitamin D supplements are added to various foods to compensate for decreased sun exposure. Additionally, vitamin D is recognized for its role in general immunity against infections, with recent studies exploring its potential link to cancer prevention. Figure 5.16 illustrates how blood vessels in the skin aid in thermoregulation. Thermoregulation is a very important homeostatic function of the skin. During heat exposure, arterioles in the dermis dilate, allowing increased blood flow to the skin's surface for efficient heat dissipation through radiation and sweating. Conversely, in cold conditions, arterioles constrict, reducing blood flow to the skin to conserve heat and maintain core body temperature.
The first and most important function of the integumentary system is protection. It acts as a barrier to the sun's ultraviolet rays and to the invasion of pathogens or germs. Through sensory perception, the body is able to respond to pain, pressure, temperature, as well as touch sensations. Next, body temperature regulation. This is performed by the blood vessels and the sudoriferous glands. Storage. The skin stores fat, glucose, water, vitamins, and salts. Adipose, or fatty tissue in the subcutaneous fascia, is stored as a source of energy. Absorption. The skin is semi-permeable, meaning substances both beneficial and not so beneficial can penetrate through the skin and into the body. At the same time, skin can also eliminate substances such as excess water, salt, and a minute amount of waste or toxins. This is called excretion. Production. The skin is responsible for the production of vitamin D by synthesizing the rays of the sun with skin compounds. Vitamin D is an essential nutrient for the well-being and functioning of the body. Albino is the absence of color pigmentation in the skin. Individuals born with this genetic inheritance lack the ability to produce melanin. The skin color is white, sometimes with a yellowish tint. Their eyes also lack pigmentation, which makes them dark pink or red and very sensitive to sunlight. Some abnormal skin colors are erythema, jaundice, cyanosis, and gray or brown. Erythema is a reddish color that results from burns and from the congestion of the blood vessels, like a slight bruise. Jaundice is a yellow discoloration of the skin, indicating bile in the blood as a result of liver or gallbladder disease, or in the destruction of red blood cells. Cyanosis is a bluish discoloration of the skin and nails due to lack of oxygen. It can be associated with heart, lung, and circulatory diseases or disorders. Gray or brown skin discoloration could indicate chronic poisoning. And the last function we will discuss is skin eruptions, which can also indicate disease. Here's a list of some of the skin eruptions. Macules, also known as freckles, are flat spots on the skin. Papules are eruptions such as pimples, chickenpox, and syphilis. Vesicles are blisters or fluid-filled sacs. Pustules. These are pus-filled sacs such as seen in acne or pimples. Crusts. Areas of dried pus and blood, also known as scabs. Wheals are itchy, elevated areas. Examples of these are insect bites and hives. And ulcers are a deep loss of skin surface that may extend into the dermis and may cause periodic bleeding and the formation of scars.
The integumentary system is susceptible to a variety of diseases, disorders, and injuries. These range from annoying but benign to severe and potentially fatal. Let's look at some of the most common skin conditions. Jaundice is the yellowing of the skin and eyes associated with elevated bilirubin levels. This discoloration signals potential liver dysfunction or an increased breakdown of red blood cells, and its presence necessitates further investigation into the underlying cause. Addison's disease, a rare disorder, results from adrenal gland insufficiency. Symptoms include hyperpigmentation, weakness, weight loss, and low blood pressure. Proper diagnosis and management are important for addressing hormonal imbalances and maintaining overall health. Basal cell carcinomas are the most common type of skin cancer, and they typically manifest as a slow-growing, non-metastatic lesion on sun-exposed areas. They are recognizable by a pearly, translucent appearance, and early detection and treatment are essential to prevent further progression. Squamous cell carcinoma is a skin cancer that often presents as a persistent, scaly, or crusty sore. If left untreated, it has the potential for metastasis, highlighting the importance of prompt medical attention for suspicious skin lesions. Melanoma is a highly aggressive and potentially lethal form of skin cancer originating from melanocytes, recognized by irregular moles or pigmented lesions with asymmetry, irregular borders, color variation, and involving size. Early detection, again, is crucial for improving outcomes and for preventing metastasis. Here on the left, we have a figure showing the yellowing in the eyes that occurs with jaundice. Again, jaundice is caused by excess amounts of bilirubin in the bloodstream. Here on the right is an example of Addison's disease. What you have is an excess hormone that gives skin a really dark brown color, and then this progresses into different colors due to reduced oxygen levels in the blood over a prolonged period. So you can see different colorizations like this ashen white color, and then also you have blue areas. This is called cyanosis. Basal cell carcinoma develops from basal cells, which are found in the basal layer of the epidermis, and they often appear as these slow-growing, non-metastatic lesions. And you usually can recognize them right away because they have like a shiny dome with an ulcer at the center. Squamous cell carcinomas originate from squamous cells present in the upper layers of the epidermis. These are usually asymmetrical with border indentations. They're often black and brown, sometimes red, and they're over 6 millimeters in diameter. The American Academy of Dermatology suggests using the ABCDE rule to identify melanomas. Look for A, asymmetry, B, border irregularity, C, color variation, D, diameter greater than 6 millimeters, and E, evolution or change in size, shape, or color over time. The EFG rule is often used as well. Look for E, elevation, F, firmness, and lesions that are G, growing in size. If you notice any suspicious moles or changes in existing moles that exhibit these characteristics, consult a dermatologist right away. Early detection and treatment significantly improve the prognosis for melanoma. There are other skin disorders that you should be familiar with. Eczema, for example, is a type of skin disorder which is an allergic reaction that manifests as dry, itchy patches of skin that resemble rashes. This disorder is often associated with a compromised skin barrier and immune system dysregulation, contributing to the persistence of symptoms. Acne is a skin disturbance that usually occurs on areas of the skin that are rich in sebaceous glands, both the face and the back. Acne involves the hair follicles and sebaceous glands. Hormones such as androgens can stimulate the release of sebum, and then excess sebum production clogs pores. And then you also can have bacterial infections that lead to the formation of pimples, blackheads, and cysts, affecting individuals of various ages. Albinism is a genetic disorder characterized by the absence or reduction of melanin production, resulting in a lack of pigmentation in the skin, hair, and eyes. eyes. This condition can also impact vision and is caused by various genetic mutations. Vitiligo is an autoimmune disorder causing the loss of skin pigmentation, resulting in white patches on the skin due to the destruction of melanocytes. The exact cause of vitiligo is not well understood, and vitiligo can affect people of all skin types, impacting both appearance and, in some cases, psychological well-being. Eczema, also known as atopic dermatitis, is shown here in figure 5.21. It produces a rash due to a combination of genetic, immune system, and environmental factors. The skin barrier is compromised, leading to increased susceptibility to irritants, allergens, and microbial invasion. Symptoms are usually managed with moisturizers, corticosteroid creams, and immunosuppressants.
While the redness and rash of atopic dermatitis are visible on your skin, the real story may be happening beneath the surface. Atopic dermatitis is more than a skin condition. It's a disease caused by an overactive immune system that leads to inflammation in your body. It is this internal inflammation that causes the symptoms you know. Atopic dermatitis is called the itch that rashes for a reason. While scratching may offer short-term relief, in the long run, you're actually making your atopic dermatitis and the itch worse. This is called the itch-scratch cycle. Your skin has 3 layers. In healthy skin, the tough outer layer called the epidermis keeps foreign substances such as bacteria, viruses, and allergens from getting in. When you have atopic dermatitis, the outer layer of skin is weaker and more susceptible to inflammation caused by immune cells in the body. The damage done by scratching also contributes to the breakdown of skin cells, making it easier for foreign substances to get in. Once these foreign substances have broken through the skin barrier, immune cells alert the body that it's under attack. These immune cells travel to the lymph nodes, which are in the second layer of skin, called the dermis. Once in the lymph nodes, these immune cells activate your body's defenders, called T helper cells. The immune cells release substances that cause the familiar redness and rash on the skin's surface. Although these substances normally go away after a short time, if you have atopic dermatitis, the cells don't switch off like they should. Instead, they continue the inflammatory process, so the skin continues to react, even when your skin looks clear. Even when you have no visible rash, the underlying inflammation is still active beneath your skin. The itching leads to scratching, which further weakens the skin cells in the epidermis, allowing more foreign substances to get in and increases your risk of infection. And the itch-scratch cycle continues.
Figure 5.22 shows the steps involved in the production of acne. Hormonal changes, particularly an increase in androgens during adolescence, stimulate sebaceous glands to produce more sebum. As sebum production increases, the excess oil, along with dead skin cells, can block hair follicles and pores. The accumulation of sebum, dead skin cells, and the proliferation of bacteria trigger an inflammatory response in the skin. Inflammation leads to the formation of different types of acne lesions, including blackheads, whiteheads, papules, pustules, nodules, and cysts. The severity of acne can vary, ranging from mild, characterized by a few blemishes, to severe, involving widespread and deep lesions of the skin.
Acne is so common that it's considered a normal part of puberty. But knowing that doesn't always make it easier. So, what is acne and what can you do about it? The hair follicles, or pores, in your skin contain sebaceous glands, also called oil glands. These glands make sebum. Normally, the sebum travels through the hair follicles to the skin to lubricate your skin. However, the skin cells can plug the pores and block the sebum. When pores become plugged, skin bacteria that generally live on the skin get trapped inside the pores. The body's immune system then attacks the bacteria, causing the pain and swelling of a pimple. Acne can show up as different types of bumps. A pore that gets clogged, closes, and bulges out from the skin is a whitehead. Blackheads are simply whiteheads that have opened. When the contents of a whitehead are exposed to air, they darken. If the clogged pore gets inflamed, it becomes a pustule. When a group of pustules cluster together, they form a cyst. Over-the-counter creams and rinses might not be enough to manage breakouts. Fortunately, doctors can offer a range of tools to combat the condition. Topical retinoid cream is the foundation of acne treatment. Retinoids are vitamin A derivatives that help clear acne by regulating skin cell turnover. Retinoids work from the inside out. The retinoic acid seeps into the cells and binds to nuclear receptors, telling these receptors to speed up their turnover process. Not only does increased skin cell turnover remove a key factor of what causes acne, namely dead skin cells, but there's another benefit. Keeping dead skin cells on the move helps keep pores clear and open so that other topical acne medications can penetrate effectively. If this is not enough, we can add benzoyl peroxide. Benzoyl peroxide is an acid that kills acne-causing bacteria on your skin. In addition, benzoyl peroxide is also anti-inflammatory and chemitolytic, meaning it decreases inflammation and opens pores. One thing to watch out for with benzoyl peroxide is that it can bleach dark fabrics. Be sure to apply the benzoyl peroxide after you pull your sweater over your face. If this combination is not enough, we'll add a local antibiotic to the treatment regimen. Antibiotics perform double duty. They're definitely after the bacteria involved in the pathogenesis of acne, but we're mainly using antibiotics for their anti-inflammatory effects. Antibiotics can be taken orally or topically, but only for a limited time. Oral antibiotics are prescribed if topical antibiotics are ineffective. Antibiotics should always be combined with benzoyl peroxide to reduce the development of resistant organisms. And finally, if nothing works, doctors will prescribe an oral retinoid. It shrinks your oil glands, preventing pimples and clogged pores. A study showed that 96% of patients demonstrated a complete clearing of their acne, and only 8% experienced a relapse. It is one of the only cures we have for acne. On a final note, this drug is teratogenic at all therapeutic doses. Fetal malformation may occur with only a short period of exposure during pregnancy and has been reported after a single dose.
Vitiligo appears as depigmented or white patches on the skin. These patches can vary in size and shape and may occur symmetrically on both sides of the body. The edges of the affected areas may be well defined or irregular, and vitiligo can occur anywhere on the body, including the face, hands, feet, and other parts of the body. The condition can progress over time, and the extent of pigmentation loss varies among individuals with vitiligo.
Vitiligo is a skin disorder in which smooth white areas, called macules or patches, appear on a person's skin. It generally starts on the hands, forearms, feet, and face. Globally, about 1% or so of the population has vitiligo. Most people who have vitiligo will develop the condition prior to age 40. About half develop it before age 20. Vitiligo may have a genetic component, as the condition tends to run in families. Vitiligo is sometimes associated with other medical conditions, including thyroid dysfunction. There is no way to determine if vitiligo will spread or remain confined to one location. Types of vitiligo. Vitiligo can be generalized, which is the most common type, when macules appear in various places on the body. Segmental, which is restricted to one side of the body or one area, such as the hands or face. Mucosal, which affects mucous membranes of the mouth and/or the genitals. Focal, which is a rare type, in which the macules are in a small area and do not spread in a certain pattern within 1 to 2 years. Trichome, which means that there is a white or colorless center, then an area of lighter pigmentation, and then an area of normally colored skin. Symptoms. White patches on the skin are the main sign of vitiligo. These patches are more common in areas where the skin is exposed to the sun. The patches may be on the hands, feet, arms, face, and lips. Other common areas for white patches are the armpits and groin, where the leg meets the body, around the mouth, eyes, nostrils, navel, genitals, rectal areas. Causes. Although the causes of vitiligo aren't completely understood, there are a number of different theories. Autoimmune disorder. The affected person's immune system may develop antibodies that destroy melanocytes. Genetic factors. Certain factors that may increase the chance of getting vitiligo can be inherited. About 30% of vitiligo cases run in families. Neurogenic factors. A substance that is toxic to melanocytes may be released at nerve endings in the skin. Self-destruction. A defect in the melanocytes causes them to destroy themselves. Vitiligo may also be triggered by certain events, such as physical or emotional stress. Because none of the explanations seem to completely account for the condition, it's possible that a combination of these factors is responsible for vitiligo. Diagnosis. Usually, the white patches are easily visible on the skin, but healthcare providers can use a Woods lamp, which shines ultraviolet or UV light onto the skin to help differentiate from other skin conditions. Treatment: repigmentation therapy, light therapy, camouflage therapy, surgery, counseling. Prevention. Since no one knows for certain what causes vitiligo, no one can tell you how to prevent it. In general, it is smart for everyone to practice safe sun exposure habits and to take good care of your skin.
Various types of skin injuries and alterations can impact the skin's appearance and integrity. Skin injuries are caused by exposure to heat, chemicals, electricity, or radiation, resulting in damage to skin cells and tissues. During the healing process after skin injury, fibrous tissue formations called scars develop. While scars are typical, keloids are raised, overgrown scars that extend beyond the original wound.
Many cuts that are isolated to the epidermis won't scar, but if a cut makes it to the dermis, it can often scar. Scars tend to look different from the rest of the skin because they aren't put together exactly like the original skin was. What I mean by that is that when the fibroblasts are generating collagen to fix the damage, they tend to not arrange it in the pattern that had originally been there before, and accessory structures won't be recreated there. Scar tissue also can have less elasticity, meaning really large scars from really large wounds can even affect range of movement. And occasionally, the collagen production keeps on going, even after everything is healed. And that could result in a raised scar that could be referred to as a keloid. That's from this excessive producing of collagen. In continuing to emphasize how important the functions of the integumentary system are, let's consider a condition where the functions can be compromised, such as a burn. The degree of a burn tends to be placed in a type of category, depending on which levels are affected. I do want to point out, though, that we've noticed classification of burn degrees are not consistent across all sources. Check out our further reading to learn more. If going on a system that recognizes 4 different classification categories of a burn, a first-degree burn generally is isolated to the epidermis, a second-degree burn affects the epidermis and part of the dermis, a third-degree burn affects the epidermis and all of the dermis, and a fourth-degree burn goes beyond these layers to even affect bones and muscles. In third and fourth-degree burns, the nerves are typically damaged, so it can actually feel less painful despite being more severe of a burn. Significant burns can be dangerous because those functions we talked about with the skin, like maintaining fluids and protecting all the internal structures, that function is compromised with a significant burn. In addition, the skin is now very vulnerable to getting infected.
As we saw in the video, burns are classified into 4 degrees: first, second, third, and fourth degree burns. The immediate danger with burns is dehydration and electrolyte imbalance, which can lead to kidney failure and shock. First degree burns affect only the epidermis, while second degree burns penetrate deeper into part of the dermis. Third degree burns extend fully into the dermis, destroying nerve endings. And fourth degree burns are the most severe, affecting sometimes even muscle and bone. Bed sores, also called pressure ulcers, result from prolonged pressure on the skin, particularly over bony prominences, causing tissue damage and open wounds. Stretch marks are indented streaks or lines on the skin, commonly appearing during periods of rapid growth, weight gain, or pregnancy, and they're caused by the stretching and tearing of the dermis. Calluses are thickened areas of the skin that develop in response to repeated friction or pressure, often on the hands or feet, serving as a protective mechanism against further irritation. Each of these conditions reflects the skin's adaptability and response to various external factors. The natural process of aging brings about changes in the skin, including loss of elasticity, wrinkles, fine lines, and reduced production of collagen and elastin, influenced by genetic factors and environmental exposure. The skin on the face and hands often display the first signs of aging more prominently than in other areas of the body due to exposure to UV radiation, thinness of the skin in these areas, and repeated muscle movements due to facial expressions and matriculation of fingers and hands. To mitigate the signs of aging on the face and hands, it's essential to adopt preventative measures such as sun protection, proper skincare, and a healthy lifestyle. Regular moisturization, protection against UV rays, and avoiding harmful habits like smoking can also help slow down the aging process and maintain healthier looking skin. Thank you guys for watching. Don't forget to do the reading, check the description for more videos related to these topics, and leave your questions for me in the comments below.